Well, a very short talk on hyperosmotic agents, which are medicines that we use systemically to rapidly and emergently decrease intraocular pressure. So we don't have patients walking around on hyperosmotic agents. They're not used chronically. And they work by drawing fluid from the eye into the bloodstream by creating an osmotic gradient. The indication is acute pressure lowering prior to definitive treatment. And the classic situation is acute angle closure attack. Or preoperatively, if one is going to operate on an eye with a pressure of 65, one can use preoperative mannitol to try to get the intraocular pressure down to a safer level. You don't want to use these in patients who are in congestive heart failure or renal failure. They really are quite potent. And in my practice, I actually don't use them pretty much ever. I'm much more likely to tap down the intraocular pressure with a 30-gauge needle than to put somebody on systemic hyperosmotics. Lots of side effects: headache, backache, confusion, congestive heart failure. You can overload these patients quickly, cause them to have a myocardial infarction, subdural and subarachnoid hemorrhage. If you use glycerol in you can cause hyperglycemia in a diabetic patient. But things like subdural, subarachnoid hemorrhage should get our attention. These are not medicines to be used lightly. They can be given orally as a 50% solution of glycerol. Oftentimes, the patients that you're using these on are people who are either preoperative or they are having an acute attack of angle closure and vomiting. So I have virtually no experience using oral glycerol. Or you can use IV mannitol. Remember, if you give somebody IV mannitol preoperatively, they are going to need some way to void their bladder because it does draw fluid out of the system and into the bladder. The dosages are around 1 to 2 grams per kilogram. So they're used, again, just a very short talk here on hyperosmotics. They're used to transiently lower the pressure. Don't use them in people who are sick, basically. If someone is fragile or frail, please don't use these medications, and they're not for chronic use. And they can have serious and even fatal side effects. So you're obviously going to learn from your mentors what kind of practice you have, how you're going to use these agents. For me, I'm more comfortable using a needle or a knife to lower the intraocular pressure. If it's in the operating room, I do that as the very first thing and gradually tap the pressure down as I'm working. Or in the clinic, you can use a 30-gauge needle to lower the intraocular pressure. But for some people, these are mainstays of their therapy of acute angle closure and other situations where the pressure is very high.